Good morning and welcome to our Employers Forum. I'm Dr. Mark Ringwelski and I'm Medical Director for Bellin's Business Health Solutions. In my role, I give medical direction for our two work injury clinics, our on-site nursing program, our on-site and in-house rehab and ergonomics and work conditioning program, as well as our drug test management program. I also work on-site with companies managing workman's comp injuries, as well as serving as corporate medical director services for managing disability cases and FMLA cases for corporations. I met our guest speaker last night, Dr. Paul Grundy, and prior to our presentation with the Bellin Medical Group providers, and I found that we both have several things in common. He is trained in occupational medicine, and we're both fellows of the American College of Occupational Medicine. Following his residency and fellowship training at Johns Hopkins University, Dr. Grundy served from 1979 to 1985 as a medical officer in the U.S. Air Force. He served from 1985 to 1994 with the U.S. State Department as a regional medical officer and counselor of Embassy for Medical Affairs in Russia and Africa, and was involved with a number of programs in those two countries. Then from 94 to 97, he served as medical director of Adventist Health Systems Pennsylvania, which is the second largest not-for-profit medical system in Pennsylvania. And from 97 to the year 2000, he was corporate occupational medical director for International SOS, the largest medical service company in the world. Currently, he is IBM's Medical Director of Healthcare Technology and Strategic Initiatives for IBM Global Wellbeing Services and Health Benefits. Does that all fit on your business card? Okay. In his role at IBM, he develops and executes strategies that support IBM's healthcare industry transformation initiatives. Part of his work is directed toward shifting healthcare delivery around the world toward consumer-focused, primary care-based systems through the adoption of new philosophies, primary care pilot programs, new incentive systems, and information systems required to implement those changes. Dr. Grundy also serves as president of the Patient-Centered Primary Care Collaborative and is an adjunct professor in the University of Utah's Department of Family and Preventive Medicine. As an active social entrepreneur and speaker on global healthcare transformation, Dr. Grundy is driving comprehensive, linked, and integrated healthcare, along with the concept of the patient-centered medical home, which he'll be talking with us about today. Ladies and gentlemen, please join me in welcoming Dr. Paul Grundy.
Thank you very much, fellow Mark. It's a great privilege to be with you here this morning on such a beautiful, beautiful fall day, and in such a prestigious places where the Packers play. It's awesome. So we're going to rock and roll here. This is a slide that comes from a report that's out this week in Health Affairs. It's a bit of a cumbersome slide, but I think it's very, very important because it really tells a fascinating story of our journey as a nation in the healthcare delivery system that we have acquired over the past 40 years or so. This is from 1975 to 2005. What it shows us is that we have the highest healthcare cost in the developed world at the lowest value proposition. What it shows us is that we as buyers of care, those of us in this room that are like me and are responsible for the care we buy, and the care that's delivered to us delivers very little value. The major indicator for that is the years of life. The percent of folks who live from 45, 15 years more. That's the most productive work years for us in business. And we're dead last, and we're dead last at the highest cost. This is our enemy. This is worse than Al-Qaeda. This is our demise. If we can't address the triple aim, if we can't begin to address higher quality at lower cost, we're in an unsustainable position economically. So I visited a large academic medical center on the East Coast recently, and I now say this to everywhere I go, but there was a giant sign on the road to that university, and the giant sign said, "We do the best heart surgery in the state." And I drove into that facility, and all the leadership were there, all the senior leadership, the O's, right? The COO, the CEO, all the O's. And I looked right at the CEO, I looked at him in the eye, and I said, "We're not ever, ever, ever going to move another job in this community. It isn't going to happen. In fact, we're moving our jobs out of this community." That's not the sign I want to see. I know exactly what that sign says. That sign says, we know the money, we know where it is, and we're going after it. I want to see a sign that says, we do the most comprehensive, integrated, coordinated care in this community. We do it so well that your employees are going to see half the rate of heart surgery. And when we need to do heart surgery, we do the best. But I know exactly where your focus is. Your focus is on high-tech, expensive, high-end procedures, keeping your beds filled, at my expense. And we are literally moving jobs, right? We have places in the United States, because IBM does data, right? We have research, we own Cognos, we do data. And we have places where if you're unlucky enough to be one of those 6% or 9% of Americans who die below 65, right? Where they're ours and not the government's responsibility because they're not yet on Medicare. We have places where it costs us as much as $177,000 statistically on average for the last 6 months of life. And we have places where it costs us as little as $17,000. Again, adjusted for variability and other things. And when I look under the covers at that, when I just ask some basic questions about why there's such differences, it's fascinating. What I see are communities that are focused, like you have been here in many ways in Green Bay, on delivering a very robust primary care system of relationship-based care, of paying attention to details. It's not rocket science. It's ABCs, right? It's aspirin. It's blood pressure. It's cholesterol control. That's the difference between 1/3 less heart surgeries necessity and not. It's not rocket science. And what I find is that in the places where it's $177,000, I'm likely to have 5, 6, 7 partialists, right? All doing a different part of the body and nobody talking to each other. And no primary care and no adult supervision at all. I mean, think about it. I mean, that's the dilemma we face, right? Has anybody read the Cost Conundrum, the report Atul Gawande did in the New Yorker, comparing two cities? A great thing. Maybe we could send to the audience. I'll send you the clip to that. It's a nice read. It compares two towns, just like I talked about the difference in variation in data. It compares Grand Junction, Colorado, and McAllen, Texas. So, from the perspective of the buyer of care, we look at places where we get high value, triple aim at low cost. Week before last, I was in South Carolina, and the reason why I happened to go there is because one of my colleagues at Boeing, my counterpart at Boeing, had recently opened a plant in South Carolina, and they were working with a primary care community there called Palmetto that were building medical homes in that community. And it was part of the reason why they moved there. In fact, it was a significant part of the reason why they moved there. We don't make a decision about where we put jobs now without thinking about the cost of health care. It's one of the parameters. We look at tax, we look at other things, but we look at the cost of health care. Why? Because it's the second largest expense for us, right? Labor's our first, health care's our second. But even though it's our second largest expense, it's the one we have the least control over. So it's the one we get the most excited and anxious about because, we don't know what cards are going to be dealt us, right? We're dependent on whether a hospital system decides they want to compete with a new proton beam inhibitor in that community as what results in our healthcare cost. Not on a sign that says we do the most comprehensive integrated coordinated care in that community, and you're the least likely to need a proton beam inhibitor here, than anywhere else. I mean, so here's the data in South Carolina. This was just out last week, and it's the reason why they moved there, right? The data, right? I mean, we saw a 36% drop in hospital days. We saw a 32% drop in ER visits. The total cost was down about 10%. We're seeing this all over the country. We're seeing it. We probably have 100 pilots that are going on now, and in report after report, we're seeing this kind of data. So we do spend twice as much as any other nation on the face of the earth. If you look at the dark blue line there, that's halfway up the graph, that's the public spend. That's the half of the cost of the public spend. We spend more than any other country on the face of the earth, other than Luxembourg and Norway, and there are 3 people in those countries, on the public spend, right? On the half that comes out of the taxpayers' thing. And then we double it, but what we as employers spend. And for what? To be in last place. We're dead last. I mean, the Portuguese beat us out this year, right? Absolute dead last. And if you go to that first slide, when you look at the data and the reason for that, right? We looked at the data. It isn't because we're fatter. It isn't because we have health indicators that are worse. I mean, look, we are fatter, but we were fatter in 1975 as well, right? I mean, the fact of the matter is that we have a healthcare delivery system that's focused on rescue care and not focused on robust primary care and prevention.